I think there is no doubt that mesh repair is superior to suture repair regardless of the hernia size. So this is something that's very important, and I'll show you that this is true, even more true for morbidly obese patients. If you do simultaneous repair, there will be a higher risk of surgical site infection. And I'll show you some data today that if you look at the peritoneal contamination, there is more peritoneal contamination in gastric bypass compared to sleeve gastrectomy. So you could do combined procedures, but if you do combined procedures, meaning you do a bypass or a sleeve and an incisional hernia repair, it takes longer and it has a little bit higher risk of complications, specifically wound complications. The one thing I would advise you not to do is you should not leave a hernia defect open at the end of any laparoscopic or bariatric procedure, because it will actually get you in trouble. Every hernia defect that when you came in was plugged by momentum needs to be repaired at the end of surgery. You cannot leave it open. And try to avoid deferring incisional hernias until the patient you're morbidly obese go lose weight, because patients get in trouble in the time you're trying to lose weight. And try to avoid just doing sutures, meaning repairing the hernia with just sutures. It might work, but in morbidly obese patients, I'll show literature that it can have disastrous outcomes. And then the last thing I think is important, laparoscopic rectal hernia repair is not a very common operation. Even though many of us could do it because we're bariatric surgeons, but this is not what most hernias get done, especially in the US. This is actually the minority. I think this is a very true statement that was said in 1948. A surgeon can do more for the community by operating on hernia cases and seeing that his recurrence is low that he can operate on malignant disease. And if I could add one thing, I think when it comes to incisional hernias, you could prevent incisional hernias by making sure your laparotomy closure, when you do any laparotomy, follows the guidelines from Dr. Israelson from Sweden of suture length to wound length, of small bites, very few millimeters apart. And I think this is not the purpose of the talk, but I think this is something that's important. So why does every hernia have to be repaired with mesh? This is the Sentinel article that was published in 2004 and practically changed the practice of incisional hernia, and people abandoned using suture from that time. In this study, they had 10-year follow-up, all in the clinic. They were first called all patients, and they brought them home to the clinic, and they found that the mesh versus suture repair is 32% versus 63%, and even for very small hernias, 17% versus 67%. The second thing they showed is that people continue to have recurrences past the second year. So recurrences happen third and fourth year. So that's why when you look at a study for hernia recurrences, it has to have follow-up in the clinic. It has to have more than 3 years of follow-up. Now when you look at cases laparoscopically, this is a large series, and in this large series of 850 patients, mean BMI of 32, it shows that you can do surgeries laparoscopically and they have a reasonable complication rate. And more importantly, the recurrence rate is actually very commendable at a new follow-up of 20 months. So there is one other point that I would like to make is you could repair hernias open like a component separation, and it's a very good repair. But the problem is wound complications. There's a much higher wound complication with component separation open repair. Second point is when you repair hernias laparoscopically, using tax only or tax versus suture, there's a difference in the recurrence rate, with the recurrence rate being lower if you use tax and suture. So let's look at, for instance, the guidelines of the European Hernia Society, the International Hernia Society, in regards to obese patients. So they say for obese patients, the preferred approach is the laparoscopic approach. And if your BMI is more than 35 or higher, the laparoscopic repair is actually preferable. And the larger the defect, you have to do more overlap. So I think this is a very important principle, is that the bigger the defect, the more you have to make sure the overlap is actually well. So let's look at outcomes of laparoscopic ventral hernia repair in patients with BMI more than 35. It's a very nice study, small study, but in these patients, BMI was more than 50, and they had some patients who had emergency laparoscopic ventral hernia repair. But I think the most important thing about this study is some had surgices, some had synthetic mesh, some had composites. Minor and major complications occurred in 1/4 of these patients, and almost 20% had a recurrence. So these are not easy patients to deal with. And the patients need to understand that because they have a BMI more than 35, their hernia repair is not a straightforward hernia repair. And it might actually have a higher risk of recurrence and a higher risk of complications. Why do I say you should not leave a hernia defect behind in laparoscopic or surgery if you can try to avoid it? Because you don't want to have like this case report. So this is a group did a laparoscopic gastric bypass, and the patient had a paraumbilical hernia. It was obstructed by momentum, so the momentum came down. They brought it down, did the bypass, but the patient presented back and died of aspiration. I think the ruling got incarcerated in that defect, and this actually is very common. This will happen. If you leave a defect behind, there's a very good chance a piece of bowel will get stuck in that defect. And usually the defect is plugged by omentum or by adhesions in the first surgery. So our approach, if we go and find someone with a hernia defect, is we leave the omentum stuck in its place and we don't deal with it. We just leave it in place. If we actually remove it, then we either put a biologic mesh, we either suture it, or we put a vicryl mesh. We do not leave a defect at the end of surgery on its own. This is another study of 85 patients, and I want to show you where they did in 59 patients primary repair, in 12 patients surgesis biologic, and they deferred treatment in 14 patients. And they watched these patients and they went to see the natural history, and they had a good follow-up of more than 2 years. There were 22% recurrences in the primary repair, and they didn't have any recurrences in the surgesis group. But it's important to note that almost 40% of the patients who were deferred presented with a bowel obstruction or incarceration. So if you get someone in your clinic and they have a ventral hernia, it's not appropriate to tell them go lose some more weight before we do the surgery, because we know as we have surgeons, they're not going to lose weight. But then you're going to have to deal with that patient in the emergency room acutely, and 40% is just too high for you to do this. Another study looking at the stage approach. So this is actually an interesting study from Charlotte. What's important about this study is that most of these patients had several repairs and they recurred. And they were also morbidly obese. So what they did is, because they had several repairs and they recurred, they decided to do the gastric bypass first. So in these patients, because they failed ventral hernia repair several times, the BMI was about 51, they did 22 open and 5 laparoscopic bypasses, had the patients lose weight, and then they actually took them to ventral hernia. This is not my preferred approach, but I think I want to show you that this could be done. And one patient required an urgent operation because of incarceration, but for the most part there were no recurrences with good follow-up in the patients. They actually did the gastric bypass first. So if you can do it, it actually is feasible to do. This is also another important study. 400 patients. They had open or laparoscopic gastric bypass, and 41 of them had ventral hernia repair. And what's important here is in 5 patients, they reduced the hernia but did not repair it at the time of surgery. This is what I told you earlier you should not do. And because of technical constraints, they just left it like that. And again, 40% of patients, these patients presented back with an incarcerated hernia. So it is not appropriate to leave a hernia defect at the end of surgery that was plugged by momentum and expect nothing would happen. 40 to 50% of these patients will come back and will have an urgent operation. So can you do combined repair, ventral hernia and gastric surgery? I think that is appropriate as long as you don't repair primary repair. I think morbidly of these patients, I'll show you that primary repair can actually get in trouble. And if you put mesh, the patient needs to know that there's a higher risk of having an infection. So this is a group of 36 patients operated between 2003 and 2011. You can see long OR time. They had 11 gastric bypasses and 25 sleeve gastrectomies. They had no immediate complications doing a combined approach and no mesh infection. Another group, 77 patients, 51 sleeves, 26 laparoscopic gastric bypasses. And in this study, it's actually a very interesting study. They sampled the peritoneal fluid in both bypass and sleeve to see which peritoneal cavity has more contamination at the end of surgery. It's actually very interesting that 0% of the sleeve gastrectomy patients had bacterial contamination compared to a much larger proportion of the patients who had gastric bypass. So I think, especially with gastric bypass, if you put synthetic mesh, the risk of infection is a little higher. As you can see here, 15% of the gastric bypass versus 0% of the patients who had the sleeve gastrectomy. This is a NISQIP study, very large number of patients, 17,000 patients, and gastric bypass in 433, sleeve gastrectomy 70 combined with a ventral hernia repair. And they found that doing a combined ventral hernia repair with bariatric surgery was independently associated with the risk of surgical site infection. And I think this is a very large study that can detect that difference. If you do few patients, 50, 60, you might not get this difference. But when you have 17,000 patients, you can actually detect that wound infection is higher when you do a combined operation. So this is something you could do, but the patient needs to understand that once you do a combined operation, the risk of infection is higher. Another study doing simultaneous repair, you can see 5% mesh infection in a follow-up of 13 months. And I think it's important to note that especially when you do resectional surgery, especially the gastric bypass, the risk of wound infection is higher. Now, this is another study of concomitant incisional hernia repair in morbidly obese patients, 54 in total, BMI is 44, and they did sleeve, gastric bypass, and bands. You can see 6 patients had major complications, and the problem is when patients had hernia recurrence, the patients need to know that incisional hernia in morbidly obese patients is not like incisional hernia in lean patients, has higher risk of complications. So again, just to tell you about primary repair, this is the study I showed you earlier. 10 patients had primary repair combined with bariatric surgery, and in some patients they deferred the repair. 34% recurrence in the primary repair. So the primary repair could actually get you just out of the operating room, but the risk of recurrence is extremely high. So I think one last thing I would like to leave you with is I don't think it's reasonable to perform combined bariatric surgery and primary ventral hernia repair if you can help that. This is a study of 325 patients, and 8 of the patients who had primary repair had bowel obstruction, almost 1/4. So this is the primary repair, patient went back, and then that repair broke, and they came back with the bowel obstruction. This is appropriate maybe we get you out of bind in a patient with the patient is not morbidly obese, but when someone has a BMI more than 40, there's a chance that repair could break. Another study, same thing. Two recurrences, and the primary repair, 100% recurrences. They compared doing mesh, doing polyester, and primary repair, and the primary repair patient did not do very well. So I think what Reeve and Silva said in 1989 still holds today. Simple suturing without tension, the deep facial layers without the down wall is not sufficient to repair hernia. So what is our approach? We try to treat the symptomatic first. And usually the symptomatic is the hernia, for the most part, especially if it has bowel in it. The morbid obesity is symptomatic, but the patient has been obese for 5 to 10 years. We start with the ventral hernia. We try to fix it with synthetic mesh with large overlap. And then we bring the patient back and do the bariatric surgery. If the patient has a significant, very big hernia, the defect is more than 10 centimeters, then those patients you have to do a component separation. You have to accept the higher risk of wound infection before you do the bariatric surgery. So I'll finish up for the sake of time by just showing you that in the U.S. in the NISQIP study, only 17% of patients are getting a laparoscopic repair. And I'll just finish up by showing you the key steps of the repair without showing you any videos. You have to get safe access to the abdomen, open or opted view. You have to make sure you do sharp adhesiolysis without use of energy sources. Because you want to see if you have bleeding, and then you have to control that bleeding rather than use an energy source. You have to measure the defect on the inside, if it's a large defect, on the outside, if it's a small defect, so you don't overestimate your mesh size. You use at least 5 centimeters of overlap, especially in morbidly obese patients. Then you need to prepare the mesh, introduce it, and use both taps and suture. And at the end of the day, you need to select your patients. I think once a patient comes in the clinic, their BMI is more than 40, they have a ventral hernia, I tell them, we both have a problem. You are not the average patient, you are going to have problems. We need to discuss what we're going to do, and the patient has to be involved in the process. Thank you very much.
Just 1 minute, we will test connection with Dr. Hamnes to be ready on time. the floor is yours.
I want to take this opportunity to again congratulate Dr. Bashir and Dr. Higa on a very nice operation, a very difficult case. Dr. Nimeri did a really nice job of reviewing some of the data regarding hernia repairs, and specifically what I want to talk about is what should we do with large incisional hernias in patients requiring bariatric surgery, and talk about why we should repair later. In terms of this study, there are several that I want you to keep in mind. One is a study out of Charlotte by Hannaford and his group that he referenced, which showed that after bariatric surgery, if you deferred to repair, there were no recurrences. Also, the study by Ramon Villani and his group that if you reduce a hernia and you leave the defect, that you have a pretty significant incidence of incarceration of that defect, so you shouldn't leave the defect. And then he referenced a couple of studies which show in the setting of concurrent repair, there were significant complication rates, including hernia recurrence. So when you talk about hernias, it really matters the size of a hernia, because if they're small, there's a risk of bowel incarceration, and oftentimes these can be repaired without mesh, even though he does cite studies that show primary repairs of a high rate of recurrence. But some of these, if they're small, you can repair it without mesh. There is some evidence for simultaneous repair. These are small series of patients undergoing simultaneous repair with mesh in the setting of gastric bypass, sleeve gastrectomy, and band. In this particular study, there were 45 patients. 9 of them underwent banding, the remainder underwent either a sleeve or a gastric bypass. And in their study, they showed basically no mesh infections and no recurrences, so they can be done safely. This is another study that looks at 36 patients out of 765 who went simultaneous repair, and these patients either had sleeve gastrectomy or gastric bypass, and again, they saw no wound infections, no hernia infections, and no recurrence. And the way they repaired it was as an underlay, primary repair of the fascia as an underlay. And then this was the study that Dr. Nimeri cited. And basically, what the study showed was that in the patients that underwent concurrent repair, there was a higher incidence of surgical site infection. However, if you look at major comorbidities and major complications after surgery, it was surprising to see that there was not an increase in significant complications associated with hernia repair at the time of gastric bypass. And in the hernia group, there was a higher presence of cardiac disease, vascular disease, and diabetes. But the problem is that in this study, they didn't really include how big the hernia was, whether there was mesh use or not. And so most of these studies that talk about synchronous repair are actually not large hernia defects. And a lot of times these can be fixed with primarily closing the fascial defect, and even when you use mesh, just using it as an underlay. And this is